March is the Endometriosis Awareness Month, I thought it apt only to talk to my surgeon who has helped me relieve of my pain, and also share the information with many others through our show. So yeah, for starters, could you please introduce yourself to our listeners?
Hi. Good morning, Padma, and it's an honor for me to be here, especially during Endometriosis Awareness Month, which where we it's very imperative to spread the word about endometriosis because there is such a lack of awareness. So I'm Dr. Abhishek Mangeshikar. I'm a gynecologist out of Mumbai. I specialize solely in the treatment of endometriosis and pelvic pain related disorders. So anything to do with gynecological related pain um, is what I'm interested in. I work with a multidisciplinary team that includes surgical units as well as non-surgical units. So surgically, we have colorectal, thoracic, urological, and for non-surgical, we have physiotherapy, fertility, and even occupational therapy, psychotherapists as well, because there's a big mental aspect of this. So we like to cover all aspects of pain as holistically as possible.
Fantastic. Thank you so much for that introduction. So we'll go straight into this. Could you tell us what endometriosis really is and why does it remain so difficult to diagnose?
Endometriosis is a disorder characterized by the presence of endometrial type of tissue outside the uterus. So endometrium is the lining of the uterus. There is a misconception that the lining is misplaced. It is not the actual lining that is misplaced. It is rather cells that resemble this lining that occur anywhere inside the abdomen, pelvis. It can be even be in the chest or in the skin for that matter. So it can literally grow anywhere in the body, and what they do is they undergo chronic inflammation, and there is cyclical injury and repair around those tissues every month. And this leads to what the hallmarks of the disease are is it causes fibrosis, and it causes disease, and nerves and blood vessels to be pulled towards it, which generate a lot of pain factors.
Sure. Um, how is it different from the period pain? Because the general belief is that, oh, this is just part of your period pain. And it'll just pop a few painkillers and it'll be okay. So, how is it different from a period pain? And this endometrium shed during the periods?
So, like I said, during a period, that is the time when endometrium is shed, which is the lining of the uterus. That has really nothing to do with endometriosis itself. Um, the disease is character. It's heightened or exacerbated during the period because there is a flare up of estrogen at that point, and you get what the sensitivity of the disease is most toward estrogen. It is also sensitive to the other female hormone progesterone, but mainly to estrogen. So, what we do experience during this time is that patients with endometriosis have heightened senses of pain during their period or prior to the onset or even slightly after. Sometimes it can also be during ovulation, um, that they do experience this pain. So, a painful period is just one of the things. But endometriosis can present with pain outside the period. It can also present with pain during intercourse, pain during bowel movements, pain during urination, leg pain, chest pain. In extreme cases, there can be lung collapses every cycle, or even not related to the cycle. That can be because of endometriosis. So much more than a painful period. And a good rule of thumb that I tell patients or anyone I'm talking to is that any pain that requires medication or an alteration in the quality of life, in terms of
Mm.
you're unable to go to school, you're unable to go to work, you're unable to attend social activities, that deserves an investigation to rule out this disease.
Talking about investigations, can you tell us how endometriosis is diagnosed and what tests or procedures are involved?
So the biggest problem with endometriosis is when we look at statistics globally, The average delay in diagnosis is between 7 to 11 years, depending on which country you're looking at. And the average patient will see between 5 to 15 doctors before getting a diagnosis. So, why is there such a big delay in the diagnosis process, even though it's such a common disease? So, the basis of this problem lies in what we're taught in medical school. We're only taught very little about this disease. Even in if you're specializing in gynecology, there's maybe just one small chapter dedicated to it, and it mainly focuses on the cysts, which are one part of the disease, and fertility. Nobody really teaches us about deep endometriosis or atypical presentations, or even among peritoneal disease, when you see the lesions that are typically described, they're described as these bluish black lesions.
Hmm.
But there are many, many other different types of lesions that occur with endometriosis that the average gynecologist is not trained to recognize even at laparoscopy. So they may miss disease even during a routine laparoscopy. And that's one of the reasons why patients suffer from such long misdiagnoses. Secondly, also, there is this inertia in gynecology to treat pelvic pain, where they will try to rule out everything before suspecting endometriosis, despite the commonality of the disease. Now, I have seen maybe pelvic inflammatory disease very rarely, maybe a couple of cases in my career, but I see endometriosis every day. Yet, the first treatment that is given for a patient presenting with pelvic pain or pain during intercourse is prophylactic antibiotic therapy for pelvic inflammatory disease. Now, that is a rare diagnosis, and it's much easier or a much more likely diagnosis to be endometriosis in these cases, but that is usually last on the list of differentials for some reason among all gynecological workups throughout the world. This is not an India centric problem, but this occurs as a pattern throughout the world. So I think a lot needs to change in terms of patient awareness, in terms of medical knowledge among our community itself, and overall there needs to be more awareness and talking about pain and coming forward. We need to talk about the in India, the familial or the societal aspect of belittling period pain, or from being called babies or saying it's part of being a woman. Grow up, have a couple of babies, and everything will be fine. And
Yeah.
whether it's this paternalistic attitude that's from the family members or even from the doctor community, that needs to change.
Um, there are, I mean, until I was diagnosed with endometriosis, I actually didn't even know that there are different types and stages of endometriosis. So, could you explain what they are, and how will that affect your treatment plan in any way, or is excision something that you generally suggest for everyone?
So, okay, let's come to the first part. So, the
Yeah.
types of endometriosis, there are three types. So, everyone is probably most familiar with the chocolate cysts. So, the ovarian endometriomas. Now, these are cysts that grow within the ovary.
Hmm.
Now, most these are very easy to diagnose. So, they're even seen on ultrasound. No matter how terrible the sonologist may be, they will find this cyst because it's quite large in general. And for routine ultrasounds, people do tend to look at the uterus and the ovaries only. Now, the thing to take away from this is that the chocolate cyst is not the be all and end all of the diagnosis.
Hmm.
So studies have shown that when you have a chocolate cyst, a single chocolate cyst, the incidence of having deep endometriosis is almost about 75%. And if there are bilateral chocolate cysts, the incidence goes all the way up to 98%. So it's almost a guarantee that you have deep disease along with it. So, and what I've seen is that the cyst is always stuck to the pelvic sidewall, and under the pelvic sidewall is where a lot of nerves and everything are present.
Hmm.
So it's not just about puncturing the cyst, draining it, and removing the cyst wall, and it is about freeing the ovary, removing the cyst as well, but also the area where it was stuck to. That is one of the main things to be treated to reduce the recurrence rates. That's the difference between expert surgery and what general gynecology will do. That's why there is such a huge disparity in the recurrence rates between the two specialties. Now, the stages, what we are commonly familiar with, well, first one is the ASRM stage, which is 1, 2, 3, 4.
Hmm.
This is not a very good staging system because it doesn't amount or account for the complexity of the surgery. It doesn't tell you which organs are involved per
Yeah.
se. It doesn't really give you an idea of anything much.
Hmm.
Um, it doesn't tell you how many specialists need to be in the room, whether you need urology, whether you need colorectal surgery, or anything of the sort. So it's not a good idea of severity of the disease. For example, I can have a stage 2 nodule that is much more difficult to do than the stage 4
Hmm.
because it can be very deep and still be classified only as stage 2. So that staging system is not very useful. There are a couple of newer ones that are improved, like the Enzian system, which basically gives a score for each compartment of the disease. So whether it's in the posterior, which is the rectum and the side wall at that level, or the middle, it's the uterus, the ovaries, or the anterior, which is the bladder and the spaces around the bladder, and of course extra pelvic disease as well. So I think the Enzian is more useful in communicating between different specialties, so between imaging and surgical specialties, as well as between different surgical specialties as well. And then there are other systems under trial right now, but this the NGN right now is the most popular among the surgeon community.
Thank you so much for that. Um, One of the things that women when they go to the gynecologist and say like period pain, and one of the common things that at least I have experienced, I know of many friends who have experienced, is what you had mentioned very briefly, the paternalistic attitude and saying have children. So, what are some of the myths around endometriosis? Does I know that now by now I know that having children won't solve this problem. So, what are some of the other common myths around endometriosis? And I'll ask the maybe the follow up question after that. But yeah,
So there are many myths which we'll try and address. So myth number one, like you said, is pregnancy cures the disease. So pregnancy, like what medication is available on the market, suppresses estrogen. It's a high progesterone state, so there is a suppression of symptoms because women are not menstruating during pregnancy, of course. So there is this temporary sense that the disease has gone or is cured.
hmm,
Even after delivery, they're breastfeeding, so there's no uh, menstruation during that time. So there is this false sense of security that the disease has disappeared. Of course, this is not true. We know this to be a fact, and that the disease does continue to grow in the background in spite of the pregnancy and the breastfeeding. So that myth, although it's still quite prevalent today, it should be
yeah,
dispelled quite aggressively. The other one also corollary to this is that menopause cures endometriosis. So they feel like delaying treatments. So someone who's close to menopause or perimenopausal age is denied treatment and said, okay, let's live with the pain. Couple of years you'll be in menopause and everything will be all right. Which is this also these myths are very dangerous because they stem into a lot of malpractice.
hmm,
So if you look at menopause, okay, if you follow that myth and you're saying, okay, I can't wait for treatment to menopause, what do? As gynecologists, we say, okay, we'll induce menopause. So we'll either give you
hmm,
medication that will induce menopause, or we'll induce surgical menopause, which is removing the uterus and the ovaries. Okay. Now, this itself is silly for disease that exists outside the uterus. Now, if a patient has appendicitis and I tell them, I'm going to remove your uterus and ovaries, the patient will think I'm stark raving mad. Now,
yeah,
when we have disease that is proven to exist outside the uterus, like in the rectum, in the sigmoid colon, in the appendix as well, how is removing the uterus and the ovaries going to be a solution to that problem? So that's another myth that needs to be shed. I have a huge series of patients who have endometriosis and endometriosis symptoms even after menopause, whether it's natural menopause or surgical menopause. So that's an absolutely false myth that
hmm,
needs to be put in the garbage. Also, there is an assumption that all women with endometriosis need IVF. So they're not treated for the disease, they're just pushed into IVF treatments. Again, which is circling back to the pregnancy cures endometriosis myth.
yeah.
And there's enough evidence to show that not all patients with endometriosis are infertile, number one. Two is surgical correction of the disease not only treats pain, it also improves fertility, that is natural fertility, as well as if a patient needs IVF, it improves the IVF outcomes as well. So that's another thing. They don't need to be pushed into IVF cycles directly. Another myth we need to talk about is that, you know, it is a lot of it comes from the theory of endometriosis going back to this is retrograde menstruation or period blood flowing backwards. So it's
Yeah,
not native endometrium that is being misplaced. We've had endometriosis in the chest cavity that's not seen in the abdomen. So how did it get there if it's misplaced menstruation blood? So there are many theories. So we cannot, rely on just treating the endometrium or the lining of the uterus, which is a lot where our medical therapies come in because they aim at suppressing the lining of the uterus. Because if all it was to do was stop retrograde menstruation, we wouldn't need to do anything except go and clip the fallopian tubes. And the
yeah,
patient would never have retrograde menstruation. She would never have endometriosis again, which we know is not true. Now, a patient may have blocked tubes but still have severe endometriosis. That's progressive over time. So this again is a fallacious theory to be working from. And there are some other silly myths that are not as prevalent that endometriosis is a result of promiscuity or women who are more sexually active or
yeah,
stuff like that. There are some really ridiculous things that you tend to hear off and on. I don't think those even warrant
yeah.
an explanation because they're absolutely so based in untruth and there is no evidence supporting them.
Right. If how do you advise patients who are being given this kind of myths even by medical professional? How should one push back? Like you rightly pointed out, I probably went to somewhere close to 6 or 7 medical professionals before I found you, and I got the treatment I needed. Uh, and I acknowledge this also takes some amount of privilege. I could do my research, but it's not the same for everybody. In this country or even the world, not everybody has that access. So how does one, as a patient, how does one self advocate for themselves that their pain should be recognized and their pain should be looked at seriously?
That's a very good question. But it's a very sad situation that's come about that patients need to do so much due diligence, need to do research on their own conditions, and so on and so forth. So it's very important for patients to watch out for these red flags when they go in for a consult. And, if they're being pushed to, if you're going in consulting someone for pain and your conversation is getting rerouted towards, pregnancy or IVF or something like that, then I would be very suspicious. And,
Hmm.
I would say, don't walk out of that office, run out of that office. Um, it is imperative that patients find good vetted resources. The good response to the doctor who tells you to get pregnant is, can you show me the medical article that says, supports your argument? Because there is none. Um,
Hmm.
if, if, if it exists, it's probably from the 1800s or something like that. But there is no evidence in recent literature that suggests anything close to something that what they suggest. But it still goes on because it's printed in the textbooks, which haven't been updated since God knows how long. Now, well, the other thing is patients have, with the age of the internet, there are tremendous resources available online. Um, so patients can get access to that research. It's free. It's not difficult to do, but they have to do the work.
Yeah.
Unfortunately, it should not be the patient's job, but the sorry state of affairs has kind of boiled down to such a situation that patients actually do need to do their own due diligence and vet the person who is treating them and look at all those resources before going in and making a decision about their treatment plan.
Yeah. Just maybe just sort of coming back a bit about the disease itself, are there any factors which make someone more susceptible to menopause? Are there any risk factors as such for this?
To menopause or to endometriosis?
No, to endometriosis. Like, does something,
Huh.
like, is it, for example, you say diabetes, for example, there, if there is there could be a hereditary cause. So is there something similar for endometriosis where there could be risk
Right.
factors that could lead to someone getting endometriosis?
So again, there's not great evidence on this. I mean, what we do know is that there's a definite genetic component to it. So it is passed on, but whether it develops and how it develops,
Mm,
there are extraneous epigenetic factors. We don't know
mm,
exactly what those are. It could be hormonal, it could be geographic, it could be, you know, exposure to toxins and pollutants, it could be dietary, it could be a whole number of things. Trauma, not
mm,
psychological, physical trauma, but on an inflammatory molecular level. If there's inflammation, that can trigger the disease to grow and
yeah.
all of that. So a lot of this, there's a lot of theory still going on and a lot of research onto what causes it, how aggressively it grows, why it grows a certain way in certain people, by people who are way more intelligent than I am. I'm just uh, good at taking out the disease. I'm not very good at understanding why and how. The What we were taught in med school is that, you know, um, endometriosis is seen more in nulliparous women. That means those who have not had pregnancies. Again, this is
Mm,
coming from Pregnancy Cures Endometriosis.
yeah, yeah.
Um, and then there was something about there was an article that was later retracted, published in the New England Journal of Medicine, that endometriosis affects women who are more beautiful because of the hyperestrogenic state of beautiful women. So estrogen was believed to be a beautiful hormone that made women more womanly, so to speak. And of course, there was much uproar about that because it was a silly article, and it was thankfully retracted. But nevertheless, it was published in one of, I would say, one of the biggest, most
Wow.
prestigious medical journals we have in academia today.
Yeah,
So that speaks to the quality of medical research out there sometimes. So you have to choose your what you say. When you look at medical research, you have to take it with a pinch of salt because for every good article, there are about 100 crappy articles that go along with it.
yeah. Does everyone with endometriosis experience pain?
No, not everyone does experience pain. And this is very interesting in the fact that someone with very early disease, that just peritoneal disease, can have some of the worst pain, whereas someone with stage 4 disease, who is on the verge of having an intestinal obstruction or has already lost their kidney because of the disease, can have no symptoms.
Mm,
There's an entity called silent kidney loss that exists with endometriosis when there's a nodule that goes and blocks the ureter, which is the tube that connects the kidney to the bladder. And this blocks up the kidney and causes it to fail on that side it's affected. The other kidney will continue to function normally. It will not show up in blood tests like the creat function or any of that because that will continue to be normal in the healthy kidney, while the other kidney has died silently without
wow.
symptoms. And this is a very, very dangerous thing that can occur.
Oh. So just as a side, so when you look into endometriosis as a doctor, how do you find the silent kidney part? Like, how? I mean, are there any signs for it, like which makes you suspect that?
Once in a while, a patient will have symptomatic pain on that side on the flank. So
Mm,
that's the under the rib cage on the side of the abdominal wall. But what we have to do as gynecologists seeing patients is we have to, when we're evaluating a patient with endometriosis, we have to routinely look at the ureters and see
yeah.
if they're enlarged and also screen the kidneys and make sure that there's no kidney damage occurring because of the disease.
Hmm.
So I think that is very paramount when we do a workup as endometriosis specialists. Like I said, a routine gynecological ultrasound will only look at the uterus and the ovaries. And It will not evaluate the rectum, it will not really evaluate the bladder or the pelvic side wall. And if there is no cyst in the ovary, a lot of patients don't get their diagnosis. Because then,
Yeah.
if the ovary is normal and the uterus is normal, and there can be a nodule the size of a walnut in the rectum, which will still get missed. And I've seen this on many occasions. They will come back with a report saying everything is normal. So
Oh, wow.
the onus comes upon the specialist to do their own imaging. So I do my own ultrasounds. I also insist on looking at the MRI imaging myself, and I don't rely on a report mainly to make sure that the diagnosis is complete.
Yeah. Um, what are some of, I know that endometriosis cannot be cured, right? But it can be managed is one of the things that's constantly told. Um, how effective are birth control pills or hormonal implants to manage endometriosis? And does it stop the growth in that sense?
So no, it doesn't stop the growth. Birth control, progesterone, the injectables, whether the GnRH, so they act on the level of the brain to suppress the ovaries. All of them work in the same way. They create a
Mm,
state of pseudo pregnancy or chemical pregnancy, or they create a state of chemical menopause. Okay,
got it.
and
Yeah.
they work on suppressing the hormones of estrogen at that level. And in that time, there is an interim relief of pain in some patients. It doesn't work for some patients as well. So it's useful sometimes in managing pain related symptoms until a patient can reach surgery. Fair enough. Um, it is not a treatment, as in it's not removal of the disease. The lesions
Mm,
do not shrink or disappear when you give medication. Patients have told me on, or even doctors have told me, I gave this medication and the cyst disappeared. I said it did not disappear. It leaked into the pelvis, which is worse. So that is something we need to understand from basic physics. Matter is not created or destroyed. It just changes state or it moves from one place to another.
yeah.
It's not like it magically vanished or something by giving medication. It definitely doesn't work for deep endometriosis. Some of this disease, when you operate, it's like cutting through sheet metal. If you try to cut through it with scissors, you can break your scissors. So I don't see how a chemical is going to have any impact upon that. But yes, for the treatment of pain, they do have a role until someone can
Mm,
reach surgery. Unfortunately, as of right now, the only effective treatment we have is surgical removal of the disease. And that is a big
mm,
problem because one is this is the most difficult surgery to perform from head to toe. And two is not many people are trained in this surgery. So it's a little bit like everybody thinks they do endometriosis surgery, but very few people actually are able to do it to the level that it needs to be done to. I've never met a gynecologist to today who says they don't know how to do endometriosis surgery. So you can
mm.
understand where the problem is.
What are so if someone says being suggested, a surgery, um, what are some of the questions that they should ask their gynecologist about what is the kind of surgery they're doing? Like, are there any like sort of like green flag questions and answers for this?
Right. So for me, this is an experiential disease. So that means the surgeon's skills can be one thing, but the surgeon's experience is very important.
Mm,
And I would say that endometriosis is a very jealous mistress as a surgical specialty, as in the fact that if you do endometriosis surgery, you have no time to do anything else because this is the
mm,
most demanding surgical specialty. So my first red flag would be if the person also delivers babies and also does other kind of gynecologic practice like IVF or whatever, or even if they do urogyne and stuff like that, then to me that is a bit of a red flag. If they're
mm,
going to be distracted by 100 other things, if they're doing the endometriosis case every once in a while, it's not going to work. Okay, it needs to be done all day, every day. So I would say the average gynecologist has never seen bowel endometriosis, or let alone done a bowel resection. A good
mm.
laparoscopic surgeon will have done one or two bowel resections in a year. An endometriosis surgeon does one or two bowel resections every week.
Wow.
So there's a huge difference in volume. So the person can even be an expert laparoscopic surgeon that doesn't mean that they're very good at endometriosis surgery or very experienced in endometriosis surgery. They may do hysterectomies beautifully, they may do fibroids beautifully, they may even do, urogynecology, it's for prolapse and all of that, very competently, and probably better than I do. But when it comes to endometriosis, they need to be doing only endometriosis surgery and
Endometriosis.
nothing else. So that's the first thing to ask. Do you do exclusively endometriosis surgery, or do you also do deliveries? Do you also do infertility? Do you do other gynecological procedures? So that's the number one screening question. Then two is, if they do endometriosis, they say, how do you work with a multidisciplinary team? How many
Mm.
procedures do you do every year? How many bowel resections do you do in a year or whatever? What are your complication rates?
Yeah.
Now, complication rates are not something to be afraid of. If you do enough surgeries or if you have enough experience, you're going to get the more complex cases, and you will have more complications the more your expertise builds. So that is not a huge this thing of disease. So of course, even I have my own fair share of complications, but it's very important to be able to identify them and manage them.
Yeah.
And those, I think, those are very important screening questions. And fourth is, what is their role or reliance? Are they able to clear disease from everywhere? Is there any area that they're unable to, feel safe to complete surgery from, for any reason? Is there any situation where they may leave disease behind? Um, is there Are they going to rely on medication to clean up the disease after surgery? That's something you
Yeah.
hear very common, like, so where they do an incomplete surgery and give medication to clean up the disease doesn't work. Um, so those, I think, those are the main questions that patients should be using to screen who can perform surgery.
Thank you. Yeah, I think that's very helpful. Um, in terms of surgery, right? Does endometriosis recur after surgery? Like once a surgery is done, say a hysterectomy or whatever, does it
Yeah.
also recur after that?
So endometriosis has different recurrence rates.
Mm.
Interestingly, for ovarian endometriomas, usually you remove only the cyst from the ovary and you don't remove the ovary itself. So ovarian endometriomas have a recurrence rate of about 10 to 15%.
Okay.
Um, the deep disease, so for rectal endometriosis, for example, the recurrence rates are much lower because you're more aggressive with that kind of
Hmm.
disease because you can remove it quite aggressively. So it depends on what technique you use. So if you're using a shaving technique where you just cut it off the top, but you leave some degree of fibrosis behind, current rates are about 6%. If you do a disc excision, which is anterior wall, the current rates are like 1% to 2% at the most. And for a segmental resection, which is for bigger disease, recurrence rates are 0.5% or something extremely low.
Yeah.
Deep endometriosis itself, the recurrence rates are between 3 to 5%. So
Hmm.
it's low. So I don't subscribe to this fact that, it's a chronic disease, it'll keep coming back. For example, fibroids have a recurrence rate of 10%. But we don't go around saying fibroids have no cure and this and that. So
Absolutely.
I believe if the surgery is done properly, yes, recurrences will occur, of course, but they will not, it's not a guarantee. And the risk isn't very high as long as the surgery is done correctly and it's done properly. Adenomyosis is a difficult entity to deal with, which exists inside the uterus,
Yeah.
endometrial outside the uterus. So, adenomyosis definitive treatment is a hysterectomy. So, yes, if you have adenomyosis with endometriosis, the hysterectomy is indicated. But otherwise, for endometriosis, there's no role of a hysterectomy per se,
Hmm.
even to stop bleeding or whatever. So, it has to
Right.
be the disease outside that's treated.
Got it. One of the things that you said is having how having a multidisciplinary team is very important, and you also mentioned that you have a psychotherapist as part of the team. Could you tell us, like, what are some of the psychological impacts of a painful disease like endometriosis?
Yeah, I think this is a very important but not very often spoken about topic. Um, so you see, most of these patients have started having symptoms from their early teens
Hmm.
or early adulthood, so to speak. And for a long time, they've been told silly things like you're being a baby, the disease is in your head, there's nothing wrong with you. And they start to kind of question their own sanity, and they're depressed because they're in pain and they don't know why, and they're not getting answers. So of course that is going to have a huge psychological impact on someone who's suffering from pain and they're not getting treatment or they're not getting answers to what the cause of the pain is. It's I've seen it sadly too many times that patients have broken down with uh, tears of joy when I've given them the diagnosis and said, it's not it's not psychosomatic pain. There's actual disease, and they finally feel so relieved to have validation that they're not, crazy, and they're not imagining their pain, and that there is an actual cause to it. They're not worried about the treatment, but they are worried about, you know, that there is something that is actually causing the pain, and that there's not something mentally wrong with them. So, and I think the years of being gaslit and the years of being in chronic pain and having to time all your life events
Yeah.
around when the pain is at its worst can obviously have a huge toll, not just physically but also mentally on anyone.
Yeah. One of the things that I know that you're part of is this organization called Endometriosis India. Could you tell us a bit more about that, and I mean, what's the kind of support or resources that you provide through that?
So, Endometriosis India was something that I came up with when I launched the center to kind of create free but evidence based um, articles and information for patients as well as for providers.
Hmm.
Uh, there are many endometriosis Indias that have come out after that. We were the first, and that have copied. There was a conference also that went by the same name but has no affiliation with us.
Okay.
Um, so less said the better about that. What Endometriosis India is, the website basically is providing content. I try to put up some case studies, share some of the latest articles regarding endometriosis, the correct information, good resources available for the disease, and so on and so forth. And a lot of it, I do try to simplify the language and not use too much medical jargon. So it's
Yeah.
accessible to patients and it's not intimidating to read. So, what we're also planning to do is kind of look at latest research articles, which, even for a medical professional can be intimidating to read and understand,
Hmm.
and kind of break it down into easy to consume um, language and put that out on a regular basis in maybe some sort of flyer or little journal
Yeah.
itself.
Just maybe another side question. What led you to doing, you do a really good job with your Instagram videos, and, what led you to do this sort of patient education almost? Um, yeah, and how was it received by your colleagues within the medical fraternity?
So the idea of putting patient things out there was that, like I said, there's a big inertia in the medical community. I would go to doctor societies and give lectures, and
Mm,
a lot of it would either fall on deaf ears or would not be significant enough for someone to want to change their practice. Of course,
mm,
there are many doctors who said, "Okay, now this is something we need to pay attention to," who reached out and came to upskill themselves as well and like learn how it's done. So there are many, many, many good gynecologists and good doctors out there. But the majority of the societies in gynecology didn't want to change the status quo. Uh, it's easier to continue the way it is rather than admit we've been
mm,
doing wrong and change that about. So then I felt educating patients was more important because a lot of patients tended to do their own research, and I felt that they should need to be having good resources. I don't discourage people from using Google, but at least
yeah,
kind of point them towards the right resources on Google or whatever search criteria you're using to be
yeah,
able to make those decisions for themselves. Um, I don't know. I think it's perceived well in the medical community. I try to keep it professional and not target anyone. I'm not out to insult or
yeah,
hurt anyone. I want to obviously put correct information out there. If I have a problem with a particular doctor, I will write to them personally and tell them what they've done, and I've seen the patient and you need to improve upon this, more often than not. And I encourage patients also to do the same sometimes. If they've seen someone and said, uh, go show them your surgical video, go show them your pathology report, and say that there was disease, you should kind of look into this a little closer. uh,
Yeah.
I do encourage that, but in a respectful way. So to engage a discourse, not to create any animosity or anything like that.
Yeah. Um, yeah. Any message that you want to give in this month, in this awareness month, that you would like doctors and patients to hear actually?
Yeah. So there's been a good movement online, which I really appreciated. I can't take credit for it, and I don't remember who said it, but it is online now. For we want to change Endometriosis Awareness Month to Endometriosis Action Month. We're aware now. We need to start taking and making changes in the way protocols are formed for this disease, how insurance companies are providing for women's care. They're not. They suck at it, and you know, to get more people trained about this, because then if you look at the spectrum of disease that is prevalent, something like 200 plus million women worldwide. And if you look at even by the numbers of an estimated 200, 250 specialists, none of them in their lifetime will be able to treat even a fraction of the disease. So there needs to be much more upskilling, a lot more research into actual causes and more effective treatments rather than what is coming about now. I just saw a new article come out from Australia saying they've got some miracle cure, which is basically they've done what Anu Malik does. They've remixed a couple of drugs and put them together and said this is some new miracle cure, which is ridiculous. They're very notorious for this. Some of these groups, they just keep putting out, sensationalist clickbait headlines and saying, "Oh, we found a miracle cure," or "There's a breakthrough in endometriosis," and it's the same old wine in a new bottle at the end of the day. So that needs to change.
Yeah. Um, because you talked about miracle cures, before I forget this question, there are a lot of alternate practitioners who claim to have, cures for endometriosis, who say, do this, change this in your lifestyle, change, you know, I don't know, like multiple things are there. So how do we address this and how do we approach this sort of a,
Yeah. So it's a very interesting thing to see sometimes. So in India, we have Ayurveda, we have homeopathy, we have everything from witch doctors. We have branding of irons on the abdominal wall. We have acupuncture and whatnot. So I say one is those allied sciences or alternative remedies don't come under peer review. They don't come under the scientific process to look to see if these are reproducible. So whatever they say is it worked for a friend of a friend, which is anecdotal evidence, which is not very high level of evidence. But I'm still not, completely where I would say, don't do this, it's stupid. I will say, okay, if you want to try it, try it. And if it works for you, well and good. But I don't see the science behind it. I don't personally understand it. I'm in no level of expertise to comment about this. So do your own work on that. If it's medical related or if it's related to the subject of endometriosis, I'm your guy. But for alternative things, as long as it's not causing you too much harm or significant investment and you're wasting your money, then I would say you can try it and see if it works for you to reduce inflammation and give you some symptomatic relief. But it's not something I would prescribe or subscribe to.
yeah, and it won't magically make the endometriosis disappear anyway. So
Not that I've ever seen.
yeah. Um, actually, there's one more question. I have a lot of questions, but I promise is the last one. Is there any particular case that sort of has sort of stuck with you in all these years of your surgical experience with regards to endometriosis?
Yeah, of course. There are a couple of cases that I experience once in a while that make me question why I've chosen to do what I do because they're very, very difficult cases. They're physically exhausting as well as mentally exhausting. The one that stands out at the top of my mind is a very dear patient of mine who still continues to be a patient and has had probably some of the worst aggressive disease that I've ever seen um, in endometriosis. And one of those cases where you have to really scratch your head about whether to, you know, operate. Are you going to benefit the patient at the end of the day? It was one of those very, very complex cases. Usually, what also the other ones that I see are those who have now had surgeries which were probably incomplete and they have a recurrence. And, the surgeries done were very morbid.
Oh,
And dealing with those cases afterwards to be the next surgeon to go in is much much more difficult. And then you like, I wish I had seen you 5 years ago is
yeah.
what I would hope to see with those patients and stick in your mind, because then you're limited by what you can do because everything is such a mess in there in an already messed up disease. So you become quite helpless. It's quite humbling also at the end of the day. And all surgeons, you know especially endometriosis surgeons, kind of revel in the crazy cases that they do because they do it successfully, and you kind of feel like you've climbed Everest at the end of the day. Um, and ones these cases are a good reminder that you're human,
Mm,
and what also makes a good surgeon is knowing when to stop and
when to
when not to
stop.
operate.